Welcome to my podcast, Why Didn't Anyone Tell Me This? With my guests, we are discussing reproductive health issues and debunking some of the myths around our health. And in this series on Beyond the Bleed, Exploring Menstrual Health, it is a great pleasure to talk to Professor Helena Teede about understanding PCOS. Helena is Director of Monash Centre for Health Research Implementation at Monash University and is an endocrinologist at Monash Health. And she holds an Order of Australia for services to women's health. Through decades of research, Helena is considered one of the world leaders in women's health, including PCOS, healthy pregnancy, and menopause. She is a strong advocate for advancing women in leadership in healthcare and research and leads the international Advancing Women in Healthcare and Health and Medical Science initiative with 22 partners. She is dedicated to impact and equality based on genuine partnership with the community, patients, and carers in research and health service co-design and delivery. Her work reaches all 195 countries and she's been awarded for her international engagement. And I know we've just been having a chat. She's very passionate about talking about lived experiences and listening to women about the issues around their health. So we're going to dig into that today. Welcome, Helena.
Thanks very much, Joyce.
So I love starting my podcast by asking my guests what led them to their career they are doing and your interest in polycystic ovarian syndrome.
So for me, I did medicine, loved it, was tossing up between different specialties. I'm very interested in obstetrics and gynecology for quite a while, but I don't do well on night shifts, Joyce. So it's a bit of a tough one because most babies are born overnight. Plus, my husband was an intensivist and we wanted a family and we can't both be out of the house overnight. So for many reasons, and also an amazing role model who was pretty much a world leader in women's health, inspired me to go into endocrinology. And so I've become a de facto obstetrician and gynecology. I've recently got my fellowship at the Royal College of O&G in the UK and in Australia, but it's been for my research, not for my clinical practice. So I suppose I got very passionate about women's health and I had two pathways and this was the one that I chose. Why PCOS? I did my training in an institution that was very strong in women's health and I had quite a passion about that area. And then I did a PhD in menopause. But when I got into practice as a women's health specialist in endocrinology, and surprisingly, I'm not that old, Joyce, but there weren't that many female specialists back then. I would go out and practice, and it was always the young women with PCOS who were the most relieved to get the diagnosis, who were the most devastated that they had not received a diagnosis, who went through the most boxes of tissues in my room and whose mother-daughter relationships were being significantly adversely impacted by not understanding a diagnosis and then really got much more empowered when they got one. So it almost felt like of all the areas, and endocrinology is a very diverse field, diabetes, infertility, osteoporosis, thyroid, you name it. But this one condition seemed to be the most neglected and the area where I seemed to make the biggest difference. And then for me, from there, I spent a bit of time doing some research in the area. And then I held a national forum where I asked the patients to head up the day. And the intention was to bring everyone together because this is a condition where we need so many specialties and so much diverse input because it has so many different manifestations. So we got them all together thinking we were going to come up with some research priorities. And we started with a lived experience. We all got together over the day. We had great patient representation. Acknowledging this is the early 2000s, Joyce, when there was no PPI or patient and public involvement, but we knew that we needed to do better. And we came out of the day going, fine, we'll do research later, but what we need right now is guidelines and education for health professionals and for patients. And that forum actually changed the pathway of my career. And so since then, whilst I do work in other areas, PCOS has been a real passion, and it's been around improving the lived experience of the condition and improving the care that women receive.
That is so important. I must say that I was a bit late coming to co-design. You were right there at the beginning, but we have to listen to people with lived experiences. We're on a different side of the table, and so important. So brilliant work that we're going to dig into. Now, let's start with the basics. What is PCOS, polycystic ovary syndrome?
Well, we'll talk about this a little later, Joyce, but the name is a major hindrance because it's not a primary condition of the ovary. It's not just a reproductive health condition, and it's not cysts on the ovary. So we have a problem because we're stuck in a historical paradigm, a name that was given when we didn't understand the condition. The answer to your question is it's a hormone or endocrine condition, and hormones are messengers in the bloodstream that are produced in one place and have an effect in another. Much like our brain sends messages to our hand to move by using our nervous system, we have another system in the body which uses hormones as messengers and allows our body to respond in certain ways. It's a very sophisticated system where we send messages from one organ to another and then feedback loops. It's very, very finely balanced. And the female reproductive system is pretty amazing, but also highly complex. And so this condition is a hormone or endocrine condition where the ovaries are part of that system, but they're not the primary default problem. The causes of the condition are genetic. It's very heritable, and often from our fathers, not necessarily our mothers. So that's poorly understood. But the genetics pass down, and there are both metabolic, so diabetes, heart disease, cholesterol, diabetes, and also high blood pressure, and also reproductive features. And that's the whole reproductive system that can be affected. Those two genetic traits then combine with lifestyle factors. And we know that in utero, when we're in our mother's tummy, if you like, that hormonal environment makes us predisposed even further to getting polycystic ovary syndrome. So it's our genetics plus the environment we're exposed to in the womb. And then the current environment in which we live, which promotes inactivity, promotes us to be less fit and less active, promotes weight gain, and promotes some of the hormonal features of this condition, is making it much worse. So, for example, we're more likely to gain weight in this current environment, and people with PCOS are even more so. And when they do, it makes those hormone changes worse. So it's the genetics, what happens in utero, and then our lifestyle, not personal behaviour choices, not personal failures, but actually the environment we're in that then promotes that excess weight gain, promotes us to be inactive, makes those hormonal changes worse, and then causes the condition. The condition itself is basically a metabolic condition. So more heart disease than earlier on, more high cholesterol, high blood pressure, more diabetes in earlier age, much more propensity to weight gain and higher weight. It's a reproductive condition, which means irregular cycles, build-up of the womb lining, which can cause abnormalities and increase the risk of womb cancer, more risk of infertility, and more recently, and very importantly, quite high-risk pregnancy, all of which can be prevented and managed, but at the moment we don't even recognise those pregnancy complications. And then it is a psychological condition, and the psychological condition includes very high risk of anxiety, high risk of depression, eightfold risk of suicide, disordered eating, self-esteem issues, and the last one is dermatology or skin. And the skin changes are excess hair growth, sometimes scalp hair loss, which can be quite distressing, increased acne and severity. And for many people of a South Asian background, and I know that population is prominent in the UK and Australia, they get what's called acanthosis, which is dark patches around their neck, under their arms, excess skin tags. So you can see that a condition that causes metabolic features, reproductive features, psychological features, and skin features, what is that? It is one of those conditions that's caused by those hormonal balances that affects all systems, and it's sure as heck not just about your ovaries. So it's complex, affects multiple areas, but the good news is that if you have a diagnosis, most of the features can be prevented or treated. The problem happens when you don't have the diagnosis and when you're not empowered to know about how to prevent and treat the features.
Wow. So absolutely much more complicated than probably lots of people listening to this actually thought about. So before we delve a little bit more into that, how common is it, Helena?
It's very common. So it's actually 12 to 13% of the population. Now, if you think about that, it's about 100, I can't quite remember, but it's 144 million women in their reproductive age, but it actually extends beyond that. And it also affects a very significant number of women in terms of pregnancy. So we're talking a minimum of 1 in 10, more like 1 in 8 women that are affected by the condition. We've just finished looking at the global prevalence, and it's the same across the world. And yet most people don't know what it is. People don't talk about it. It's a taboo topic. It's just about your ovaries. It's one of those women's health secret conditions. Nothing like what we know about diabetes, which is less prevalent. And yet, in fact, this condition has a bigger impact on quality of life than diabetes does. So it's one of those secret women's health business that really needs to come out of the closet, a lot like endometriosis did, where we need to recognise it is very common. It can have significant effects, but we can prevent and treat.
Comparing it there to diabetes and how much more important really this is, and I'm not undermining diabetes at all, but the fact that there's so much we don't know still, and people don't know. So I recently did some research in a number of countries where we asked 16 to 18-year-olds a number of questions about reproductive health education. And the most upsetting piece of data from that research in every country we looked in was that we gave them a list of reproductive health topics and said, have you learned about these in school? And on there was obviously PCOS and endometriosis. And in all the countries, it was just a few percent, literally 2 to 3% of 16 to 18-year-olds knew anything or had been taught anything about PCOS and endometriosis in schools. And that broke my heart. I just thought, this is unacceptable. If we start in schools and teach young women about these two disorders, we will absolutely improve the diagnosis and treatment, which, as you say, is such a high percentage. So what do you think about education in schools?
It's critical. Indeed, our research around the world has showed that the average woman who gets a diagnosis, or adolescents especially, has seen 2 to 3 doctors and can take up to 2 years to get a diagnosis. But the most devastating thing is when they don't get a diagnosis. So they come in with symptoms like irregular cycles or excess hair growth or more severe acne, and they're sort of told, oh, look, the treatment, go on the treatment, which is the pill, also provides contraception. It's a good treatment. Despite what's on TikTok and social media and all the influencers saying, no, take my lemon diet or take my supplement, actually the pill is a good treatment for this condition. But the problem is if you don't have a diagnosis, the pill only treats part of the condition. And if you are put on the pill early in adolescence and you're not given a diagnosis, you don't understand why you're different. You don't understand and you're not empowered to have insight into the condition. And we've just published on this recently, in fact, only a few weeks ago. If you don't get a diagnosis before you go on the pill, most young women just happily continue on or continue on with features that they've still got, like their anxiety and their depression, and they're more likely to get disordered eating and other features that are not treated by the pill. But more importantly, they're not empowered for family planning. And so they willfully go along and then in their usual, as we know, of early 30s now for many women, decide they're going to come off and have a family, at which point they don't know that they've got this condition. They don't know that they'll have quite a high rate of infertility. They do not know that most of the treatments for infertility will work, even simple treatments, and will improve the likelihood of having a family. So what we've shown is that if you have a diagnosis when you're an adolescent and you know about the condition, many women will choose to have their family a little earlier. So rather than in superimposing the effect of age, and the effect of unhealthy lifestyle and higher weight with the condition, they plan and they actually have their family on average 3 years or so before because they go, well, I won't wait for that promotion and I won't quite worry so much about paying off my house because I want a family. And so I'm going to be a proactive planner. So when they are diagnosed, they make those decisions. And then more importantly, when they make those decisions, the moment they come off the pill, if they're not having their period, they go straight in and say, I need help. And they get it. So what we know is they can have the aspirational family size they want, whatever that happens to be, and they're very likely to have a family. Very likely. So this diagnosis does not mean you're infertile and you won't have a family, which is one of those myths that's propagated. Whereas if you don't get the diagnosis in adolescence, you're put on the pill, there, dear, take this, you'll be fine. And they go through their life without any of those other features being validated or treated. They come out thinking they're going to have a family. It takes a long time to get the diagnosis, it takes a long time to get to the infertility specialist. There's a higher risk of never having a family. There's a much higher risk of not reaching your aspired family size. There's a much higher risk of having more costly, more invasive therapy. And yet our paediatricians is one of the fascinating things, Joyce, when we put everyone together, because I've now led 2 international guidelines in this condition. Probably one of the most important things I've done in my career, and I've done a lot of research because it got everyone to come together with women with lived experience who were front and centre in the initiative, including the amazing group from Verity, Rachel Morman and Catherine Andrews and others, who really had a strong role in that. But it was about how we improve the research, education, care and outcomes for women with the condition. And one of the really important things was when we put the paediatricians in the room with the general practitioners, with the women, with the infertility specialists and the diabetes people, we put them all in the room and listened to the women. The paediatrician said, oh, no, please don't diagnose them. We don't want to worry them. We don't want to label them with this condition. Now, we never say that about diabetes or epilepsy or high blood pressure, but for some reason, we don't think it's appropriate to worry young women about conditions like this. But the problem is, they said, look, we'll just treat it. We'll just put them on the pill, because the paediatricians are not seeing the reproductive outcomes. They're not seeing the long-term anxiety and depression that's not being treated. But when you put them in a room with a whole range of quite well-informed, feisty women who've not been diagnosed, and then with the reproductive IVF people who say, you can't do this because we're dealing with the aftermath at the end. And then the women quite rightly said, what right does a doctor have to paternalistically decide you have a condition, but we're not going to tell you about it, dear? It's fine, we'll just treat you. It becomes a very patronising concept. So what we have actually done, which I think probably again is going to be one of the most important things I've contributed in my career, is we redefined the diagnosis. A lot of our paediatricians were concerned because there are a couple of features that make the diagnosis in this condition, one of which is irregular cycles when you're not on the pill or skipping missing cycles. Another is that excess hair growth or quite severe acne. But the other one is having what they call cysts on your ovaries on an ultrasound. Now, importantly, they're not cysts. They're half-developed eggs who've gone back to sleep and are not developing, but they look like cysts, so they call that an ultrasound. Turns out, in adolescence, they're completely normal. Our reproductive system is just practicing. So using them in the diagnosis has a risk of overdiagnosis and labelling women when they potentially don't have the condition. So by being able to use evidence to refine that and remove that from the diagnostic criteria as an adolescent and only introduce it in adulthood, we really reduce the risk of overdiagnosis by getting our paediatricians to listen to the lived experience and by providing them with evidence to show that if they don't make the diagnosis, they are not empowering the women and they're not leading to better outcomes in the long term. We've managed to really flip that around to say we as clinicians have a mandatory responsibility to go on the journey, to do some shared decision making around that diagnosis, and then to make a timely diagnosis, but make sure women have the right information. So we've shown if they've got information, Joyce, it doesn't promote anxiety. And so that's really important.
I totally agree. Giving people the information so they can make an informed choice is essential. They're not stupid. You know, we shouldn't worry about worrying people. We've got to give them the right education. And it's unbelievable that people would say that. Oh, don't tell them we might worry them. But you've absolutely done the right thing. And this is what I try to do. Get everyone around the table so they can listen to the full story. So absolutely brilliant work, Helena. This is so important. So you've mentioned the symptoms that such as irregular cycles and acne and hair growth. Are they the main thing? If you were going to a school and you wanted to alert young girls to think about the possibility of this, are they the main symptoms that you would say, if you've got these, you might want to go and see your doctor? Or is there anything else?
Definitely. Yeah, so they're the main things, but I also think that so we know in adolescence they're the most prominent for the diagnosis. It doesn't mean they're the only features. So that anxiety, depression, self-esteem, body image. So you can imagine that if you are a young girl who is, say, 15, you're not getting your cycles regularly like your peers. You're having long periods without getting a period, and then all of a sudden it's incredibly heavy with the embarrassment and other problems that can come with that. And then also you're getting excess hair on your face and your stomach and your areas where you don't want to expose yourself in exercise in the gym, which increase self-esteem issues. You'll put on weight selectively around your tummy. So you might keep fairly lean arms and legs, but you get quite a significant distribution of increasing weight, but also around the tummy, which makes that self-esteem issue worse. That often can contribute to disordered eating, and all of that contributes to anxiety and depression. And indeed, the prevalence of depression symptoms in this condition are around 80%. So I think the most important thing is picking those first two. Are you having irregular cycles, or are you skipping cycles? Are you noticing excess hair growth or even slight thinning of the hair? Acne is challenging in adolescence because it's common. So it has to be more severe acne. But what we normally say is if your cycles are irregular or if your cycles are painful, you need to go and see someone about that. And that's probably the most important message for young women. If they don't have irregular cycles or they're not having long periods without their cycles, they're unlikely to be diagnosed in adolescence. So that's probably the really simple message. Normal, regular periods, once you're 1 to 2 years into after puberty, are a really important thing to know you've got. Once you're on contraception, that's a different issue. But until then, if you don't have that, go and have a chat to your GP about that, because that's, I think, one of the most important messages we need to get through.
I'm very happy because that's exactly what's on my slides. And our International Reproductive Health Education Group have produced a resource for teachers. And there's just one slide on endometriosis and one on PCOS, because I don't think it's rocket science. You know, you've said it there, and that's exactly what we've said. It's not about having children in the future. It's about their health and quality of life right now. But I find the work I'm doing the work teachers don't want to talk about abnormal or things not being right. So they don't, they're a bit like the pediatricians. They don't want to rock the boat. So they talk about a normal menstrual cycle, but in my experience, not all obviously, but many of them don't want to make any girl that's listening to their lecture think, oh, there's something wrong. But I think that's incorrect. I think we've, as you said, the importance of flagging this early, because so many of these issues are going to absolutely affect a teenage girl's self-esteem and quality of life. I mean, it doesn't make sense not to flag it for me.
No, it doesn't. It doesn't make sense. And when you think about it, if you broke your arm, you wouldn't say, don't worry about it, it'll be fine. You would say, you've got a broken arm. But, you know, and likewise, we're reducing the stigma about mental illness, but for some reason we have not reduced the stigma about reproductive conditions. And I think that the thing that we have to do, though, in making young women aware is make sure that our GPs are reciprocally aware, so they're actually listened to when they go to attend a consult, and that they have other ways of being empowered. So, for example, our Ask PCOS app, which is literally called Ask PCOS, is now used in 195 countries. It's free. It's got 15 different languages. And we just funded at the moment to include a whole range of shared decision aids on there. And so they literally take, in quite appropriate health literacy language, they take a young woman through, and their guardian, if they're particularly young, could go through it with them, through the choices of, should I explore this diagnosis? What will it mean for me? What tests might I have, and how can I make those decisions? And when I do get a diagnosis, what can I do to improve my quality of life? What can I do to prevent the features? What are my treatment options? So there are all sorts of shared decision aids that really take you on the journey, and actually, in a sneaky way, are meant to both empower the patient, but also empower the patient to help the doctor to be more informed and make the right decisions. So they are shared decision tools. They're not replacing the clinician, but they are designed to really make sure that the two people can work together, to the point where it's all co-designed, but to the point where it sort of talks about what is PCOS, gives you the features, and then it says what is a hormone, and it talks about the different hormones. And then when you get to, well, what is my hormone level and what does that mean for me? That personal question drops into a little checklist, which is there for next time you go to see the doctor. So the doctor doesn't need to explain what PCOS is and what a hormone is, which can take a long time, and what the long-term features are. But the doctor can explain, well, what are my hormone levels and what does that mean for me? And likewise, you know, and you can only ask 2 questions each time because you can't inundate the doctor. The app controls that. But in terms of things like, okay, I know this condition may affect my fertility and there are things I can do to prevent that. You know, what do I need to think about? When do I need to plan my family? You know, if there's a suggestion, I might want to think about that earlier. So there's all sorts of things in there that prompt a much more informed decision. And we know that knowledge and shared decision making reduces anxiety, improves quality of life, optimizes empowerment. And I think, in my experience over 3 decades of working in women's health, that sort of traditional patronizing approach to We won't talk about it. We won't worry them, as opposed to let's talk about it. Let's empower them. Let's make sure that they can actually prevent the features of the condition, and let's make sure they can work with their doctors and not listen to misinformed, self-promotional influencers who are filling a gap because they're not getting enough information and actually promoting basically incorrect information, such that the pill's bad for you and my lemon diet will cure you.
Yeah, we'll talk about social media. So we'll put the link to that resource in the show notes, because that is absolutely essential. Everyone needs to be aware of that for sure. So let's talk a little bit about how it's actually diagnosed. So I totally agree that with any women's health issues, I think we need to educate ourselves and then go to the doctor armed with that information of what we think we might have. I don't think the doctors have time to, or the background to educate us. So things like menopause and things, lots of women are going to try and find education at their doctors. So I think education of women is essential, and going armed with that information. So when you go to the doctor and they suspect PCOS, what happens next? How is it diagnosed?
So the first thing is to talk about the condition and the opportunities to make a diagnosis and why we want to make a diagnosis, because it does allow people to be empowered to find out information to prevent and to treat the condition. So the diagnosis is quite important. The really good news is the guidelines spend a lot of time sorting out exactly what tests we need and don't need. And the fantastic thing is we don't need many. So for 65% of women, if they have a history of irregular cycles, menstrual cycles, and they have excess hair growth when the doctor examines them, that's all they need. They just need one blood test to exclude other causes which can look a little like this. And that's only a few simple low cost tests. And that's it. They have a diagnosis. And so for 65% of people at any age, that's all they need is a history and an examination. In fact, they could probably make most of the diagnosis themselves, except for excluding those with a few other tests. And that's all in the app that explains that in a shared decision-making tool. If they have both of those features, they have the condition. And if you're an adolescent under the age of 20, you need both. But if you're an adolescent and you only have one, you can't make the diagnosis on the basis of one. You're just at risk, but you don't have the diagnosis. But the other tests, which are about the ovary ultrasound and those little follicles or cysts, as they're called, that is not appropriate to do in an adolescent because they're positive too often. They're in a reproductive system that's still practicing. So in adolescents, you have two, or if you have one feature, you're at risk, and you come back and get checked later on. And so that's the end of the journey until you're 20 for an adolescent. If you are an adult, you have both, you have the diagnosis. If you only have one, for example, irregular cycles, and we see this a lot in women from, for example, many of the Asian countries, not the South Asian, but for example, China, Taiwan, Japan, Philippines, Malaysia, they tend not to have those hirsute appearances. And so for those women, we will need to do a blood test for the male type hormone or androgens. So that's only a relatively small number of women who need that. And if they have that, they've got the diagnosis. For about 25 to 30% of women, if they don't still have those two features, irregular cycles, and either the hair growth or the blood test androgen, that's only then that we need to do the ultrasound, which is expensive, hard to get, not particularly pleasant to have. Then we may need to do that ultrasound, or there's now a simple blood test you can get instead of the ultrasound, cheaper, more accessible. So one of the shared decision aids that's about to come out on that Ask PCOS app shows women the choices they have as they go through those tests. But in essence, most women need a single blood test, a history, and an exam. And some women, small number of women, need an ultrasound, and only if they're an adult. So the diagnosis is actually not that difficult. And in fact, the guidelines have gone a long, long way to making that much, much easier for clinicians and for women to understand that diagnosis.
I've seen some women's health tech companies who, it's a huge exploding field at the moment, and I've seen some of them talk about helping you diagnose PCOS and do all sorts of other things. Some of them I don't quite understand. One of them, they said we all diagnose PCOS on menstrual blood, which made no sense to me because, as you said, most women don't need a blood test and most women don't have a period, so why would you do it on menstrual blood? But what do you think about these tech companies, I worry that many of them are exploiting women rather than empowering them. I had Tessa Kopp on my podcast before talking about exactly that and around AMH testing. So we don't need to worry about high tech stuff to diagnose
No.
PCOS. Is that right?
No, not at all. So AMH testing is a real challenge around menopause, but in fact, AMH testing is appropriate for adults for PCOS. So we've just got to be careful where we're talking about the AMH testing. But it is definitely true to say that for women, one of the things we've got to realize is what is the person who's promoting a test or a tech or a particular product making out of it. Now, as much as we might be skeptical about the influence of pharma on medical professionals and the occasional pen we might get and what have you, the reality is doctors in the UK and Australia and most places around the world, actually, besides an occasional pen and an occasional meeting, which we have to declare anyway, when we recommend something, we get no advantage. We don't get paid anything if we organise a test. We don't get paid anything if we organise a particular medication. And especially if we follow guidelines, because those guidelines, and indeed our PCOS guidelines, are about to be, Joyce, the only international guideline on any condition anywhere in the world that are going to be adopted by NICE. And that is going to be a fantastic process because they were very rigorous, because they had strong UK involvement. So they're going to be adapted for UK, but they're going through that process, including the app and the resources. And I think one of the things about that is women can be really reassured that that was an incredibly rigorous process with the best evidence, with total transparency, with no drug company influence. No one in those rooms was able to be influenced by money from anyone else, and they had to declare that. And what's more, there was lived experience at the table through every step of the way, including the way it's communicated. So I really think what we need to do is make sure that women have access to reputable, high quality information that allows them to work with a health professional. And why would a tech company be offering you direct diagnosis of your PCOS if it wasn't to make money? Why would an influencer say, I've got the answer to something if it wasn't to make money? And the misinformation that's out there about the oral contraceptive pill that's almost become, sort of persona non grata is really disappointing because for so many young women, not that long ago, it was the most liberating thing to be able to control their fertility. And it is a really effective medication for this condition. But it just gets dished by social media influencers when the evidence that we have is it does not cause a deterioration in mood in this condition. And in fact, it improves quality of life because it impacts the symptoms. It's not for everyone. There are contraindications. Like anything that works, it has side effects. So it may not be for you, but you go on an open-minded journey and you rely on evidence. Here's the benefits. Here's the risks. Here's my personal scenario. I either choose to take it or not take it. And you don't get told by somebody who's, got a body mass index of 19, who spends their entire life looking wonderful as an influencer, telling you about the fact that they went on their lemon diet and it's cured the problem and don't ever take the pill. And I get really passionate about that misinformation because I think in part it happens because of our failure to educate young girls in schools, to educate and empower and respect women in consultations. And also our doctors are not well educated. We get an hour, maybe two, in 5 years of medical school on PCOS. If you're a midwife, there's nothing in the textbooks. There was just written about this recently, even though it's a high-risk pregnancy condition. If you're an obstetrician, you get taught about PCOS in the gynae part, but you don't get taught about it in obstetrics. If you're a cardiologist and they've got more heart disease, you don't know anything about PCOS, and they're not mentioned in the guidelines. In diabetes, most of them don't consider PCOS. So you've got this sort of problem where because it's been secret women's business, it's only been funded under reproductive health, which means it gets zip money, and all the research is in reproductive health, not the other features. It then doesn't get the evidence which influences education and guidelines, which influences care. And the name, polycystic ovary syndrome, puts it in a secret women's business box and just does not allow people to understand the breadth of the condition, which just perpetuates the whole problem of the condition in the first place.
Yeah, we are in a mess. And I don't think we should blame the doctor that we're sitting in front of because, as you said, they haven't been trained and we're all trying to sort this out. But it's important that we all get the right education about this. And so Let's talk about managing and treating PCOS. So, and you've mentioned social media, and there's so much on social media. There was comment the other day on someone else's podcast that you can cure PCOS by lifestyle, and there was another one recently, probably more accurate, talking about walking, sunlight, protein, blocking blue light, weight, sleep, that can reduce symptoms. So what do you feel about lifestyle? But you've mentioned the pill, but if they take the pill or not, how important is lifestyle to try and get this condition under control? And can we cure it?
So lifestyle's fundamentally important. And whilst I've talked about the pill, it's in the context of social media that's inaccurate. But we've always said that lifestyle is probably one of the most important components. And to me, lifestyle includes empowerment, education, and understanding of your condition. It's sort of a holistic approach. So that empowerment is part of it. That we have to be really careful here. So lifestyle, which means a person's behavior in the context of their complex environment, which is pushing them to be inactive and pushing them to eat ultra processed, low cost food, is not the fact that 70% of people in the UK are overweight is not a personal failure. It's not a behavioural choice. It is absolutely and paramountly about our environment. You know, our parents, our grandparents were rarely overweight. You look at photos of the beach and the football and the soccer, you know, even 40 years ago, nobody was like that. Even in Japan, they have a 3.5% rate of people who are in that really high BMI range. It is absolutely our policies and our society and our environment that's doing this to people. And we need to get over our blaming individuals and stigma around excess weight. But the reason I bring that up is because in that what we call obesogenic or really unhealthy environment that we're in, where there's so much high processed food, what we see is this scenario where people then get to quite a high weight, which we call in the unhealthy weight range. And then they're simply said, move more, eat less, go and fix this yourself. Healthy lifestyle will fix everything. The challenge is that, yes, if you can restrict your lifestyle, and it takes money, because it takes money to be able to exercise and make the time and eat healthy food and afford all the things that we need to afford to be healthy. If you can do that and push your wheelbarrow full of cement up a very steep hill and actually stay healthy, then yes. But the reality is 1 in 1,500 women, actually 1,500 people, can use lifestyle alone to control their body weight from that very unhealthy range into a healthy range. And yet we spend squillions expecting people to do that. Weight Watchers, you know, you name it, right? Once you're in that really high unhealthy weight range, you have a medical condition and you need medication. And I hate saying this because I'm a public health physician, but you need medication or surgery or something extra to help you if you want to get the weight down. However, no matter what weight you're at, a healthy lifestyle will make you better. It will help your mental state. If you're having good sleep, it will help your mood. It will help your conditions. It will help you feel better. If you have more muscle mass, if you're doing more exercise, it will make you healthier. So a healthy lifestyle where the target is, I want to be the best I can be, is really, really important. But a healthy lifestyle where I say to someone, go and lose 20 kilos, is a fallacy, is setting someone up to fail, is just so profoundly unfair in the environment that we have that I actually think it's almost to the point where it's immoral and unethical to do that. So the answer is lifestyle is really important. It requires support, but our goals need to be realistic. And it doesn't matter whether your body mass index or your weight is in the healthy range. Being the best life, the healthiest you can be is terrific. If it's slightly above that, really important. If it's very high, still really important. But we can't expect lifestyle alone to be the answer to dramatically reduce weight, because when you, no matter which influences diet you use, when you have a healthy lifestyle and you drop your calorie intake, your body, your hormones are really good at making sure you don't lose weight. They all go up and make us wonderfully efficient because they don't want you to lose weight because they think you're going to starve to death. And they will push your body to be super efficient and metabolic. And even if you can really cut your calorie rate down, which is very hard, you'll hit a plateau. How many times have we tried to lose weight? We lose a few kilos and we stop. And then unless we restrict more, we just can't go down again. And then inevitably we gain to more than what we were before, because our bodies will push us to always be a minimum of the weight that we were at our highest, which comes back to why we want to tell adolescents about this. Because if I said to someone early in their life, whatever your highest weight is, like even after Christmas, there's a wonderful article in the BMJ many years ago saying every Christmas we put on about half a kilo and we don't lose it. So we have to be really careful at Christmas and eat quarter of our mince pie, not the whole mince pie, because we can't just have those little indulgences, because we'll keep them. And so that thing about empowering people to think about their lifestyle in the context of prevention, rather than thinking about a healthy lifestyle in the context of treatment, where it's just unfair. So lifestyle is really important, I think, and Joyce, critically important, but with the right goals and not setting people up to fail. So it's first line treatment in the guideline. First line and really important for women with this condition, and we recommend they're supported in that journey, but that they have realistic goals.
Here, Helena. This podcast actually was going to go out on Christmas Day, but I've moved it forward. So it's coming out a few days before Christmas Day, so our listeners can think about their mince pie, put it down. But I've become quite obsessed about lifestyle. I've always exercised my whole life. I used to be an aerobics teacher when I was doing my PhD. But actually, I'm supposed to be at Body Attack at this moment in time. So, but I'm going to I'll make up for it. But you're so right. The ultra processed food. There's a big movement in the UK now to tell people it's not your fault. You are bombarded by marketing. I mean, it is almost impossible. Even I cook almost everything. I'm even cooking all my own bread now. But even the Christmas things, I have gone and bought a few those Christmas treats, they're all processed in a box that you stick in the oven for 10 minutes. And then, so it is so hard in today's society to understand this processed food and be bombarded with this information. It's lifestyle is really difficult. I think that's one reason why in schools they hesitate about talking about things like PCOS, because they don't want to talk about weight. So I think that's a real problem as well.
So I think the other thing about lifestyle is we have to recognise the issue of stigma, because that personal blame is still there, Joyce. And it's not just educating people about their food; it's actually regulating the industry. If people really understood what they were eating, they would understand why we're struggling. I mean, my grandparents ate 3 square meals a day. They had dessert, they had treats, they had cakes, they had scones, but they were active and they were all eating whole foods. The amount of absolute garbage in what we're eating. I mean, the composition of Krispy Kreme donuts is like the perfect chemical laboratory combination of fat, sugar, and lack of satiety, so you can keep eating more. And it's designed to do that. It's chemically designed to trick us. So I think what we have to recognize is that that even baby food is full of sugar. We need governments to step up, and we need to recognise that big food is worse than big tobacco. They learned all the lessons from big tobacco, and we are being completely duped. So when we get better regulation, we get better formulation, as you've seen in the UK with your sugar tax. Well done you. Australia still doesn't have it. And so those sorts of things start to make it easier for people. Putting levies on unhealthy food and then using that to subsidise healthy food and making it easier for people to make healthy choices is really important. But because we believe it's a personal failure, if you have an unhealthy weight, it's your fault. And so that comes with blame, it comes with stigma, it comes with shame for 70% of the population, but especially for young women. And so what we've now got is people don't want to talk about weight. They won't talk about weight because it might bring stigma and shame. Whereas what we really need to recognise is that not recognising unhealthy weight as a major risk factor for health actually again treats the population like they're not intelligent and capable of understanding. If women understood from a young age, and if they were helped and supported around being as healthy as they can, and recognising that one of the main drivers for their successful fertility and having a family is actually being as healthy as they can and trying to plan their family a little bit younger if at all possible. And if they realised how much impact it was going to have during pregnancy, and if they realised that when you're pregnant you don't eat for two, You eat for 1.1. You eat for 10% higher. And you don't become rested or confined when you're pregnant. The best thing you can do is keep walking and keep active and do things so you're fit for when you go to your delivery. But what we tend to find is that we now don't talk about weight anymore because it brings stigma. I think what we need to be doing is not talking necessarily about weight, but talking about health and being positive and open to the fact that people who are often challenged by weight have exposure to unhealthy food, have lack of opportunity around healthy lifestyle. We know that income and education are critical determinants of whether or not you can choose to be as healthy as you can be. We know that single parent families are often much, much tougher environment to be as healthy as you can for you and your children. And so we need to recognise it's not about personal blame, and we need to make this much more a focus on health and much more a focus on shared responsibility with government and with industry and with regulation, and create a healthy environment. And as a population, I actually think we need to stand up and say enough's enough. Why are people allowed to feed us ridiculous rubbish without us being aware of it, purely for profit? So I think in that context, we cannot not talk about healthy weight, but we need to talk about weight in the context, or in fact, not so much weight, but lifestyle and health, and how we can be the healthiest we can be, and recognise where the problem lies and support people to do that in a positive frame. We can't deny, and this, this move about health at any size, it is true, no matter what your weight, you can be healthier by being active and by eating well. But it is not true that that takes away the risks associated with it. So that pendulum has swung way too far, and in fact it suits industry and it suits the lack of government gall to not regulate this problem for us to not want to talk about it anymore. But we can't not talk about high blood pressure and not talk about smoking and not talk about drugs when we know they have health impact. So as doctors and as health professionals, it's really important for us not to do that and to recognise we need to change our language, we need to be respectful, we need to remove the blame and stigma, we need to understand where the problem lies, and then we need to support people to be the healthiest they can be and not set them up with unrealistic targets that they can't achieve.
Yeah, and this comes up in, I think, every podcast I've done. Lifestyle it's a preventative medicine, so we've got to get on board with this. So going back to PCOS, so we've got the pill as a treatment and management. We've got lifestyle. Is there anything else that any other treatments that women might be helpful to them?
Yeah, so there was a recent, and I think, can I just emphasise that lifestyle is really important? Sleep, personal well-being, education, empowerment, preventative planning. So I would suggest, as you were talking about before, that young adolescent girls in school need a reproductive life plan. If they have endometriosis, if they have PCOS, if they have other features that affect their reproductive health, and that's not just about fertility and pregnancy. They need a reproductive life plan that takes them through to menopause. And I was explaining to our health minister recently in Australia about this. Men and women both have their own health conditions, but on top of all of the health conditions that women have, we have a very significant reproductive health burden that starts in adolescence and goes through to menopause. And that is over and above what men have in terms of their male health. There are some aspects of male reproductive health which actually primarily affect men much later in life. They can have infertility and they can have prostate cancer. But for women, there is this really massive parallel burden, and we don't really provide any extra help or support. So that concept of educating young women at school about this, but then also giving them that empowerment of a reproductive life plan to optimise their reproductive health and their long-term health is really important. So to just emphasise that is critical. Healthy lifestyle is critical. The pill can work. It works for some parts of this. So it will protect the womb lining. It reduces the male type hormone that's circulating. It is good for the excess hair growth, but it takes 6 months to a year to work. And it's even better if you're combining it with laser therapy for the excess hair. So it works for those things. It doesn't necessarily make any difference to weight. It doesn't make it worse or better, but it doesn't necessarily do that. Whereas other treatment options, such as metformin, comes from lavender originally, been around for 100 years, about as natural and cheap as you can get with very few side effects. It can cause a bit of nausea, can cause a bit of diarrhea, and we may have to adjust the dose. But actually, it's quite a good medication for this condition. especially in some groups such as the South Asian, Indian, Sri Lankan, Pakistan origin population, because they seem to have a predisposition that makes this medication more effective. But essentially that can help with that dark hair, a dark skin changes I mentioned. It can help with the diabetes risk. It does help prevent weight gain. So it can make quite a difference in weight over time. It may cause a little bit of loss, but it's not really a weight loss drug, but it can help that prevention. So there are reasons you would do it, but it doesn't help hair. For example, it can do a bit to help the regulation of the cycles. It may be enough to protect the womb if you're having regular menstrual cycles on it. It can even induce pregnancy. Not as effectively as some of the infertility drugs, but it can work and it's cheap. And if you're not in a big hurry, sometimes it can be quite effective. So it can often be a first-line treatment there. Laser, quite good for excess body hair, but you need to remember that if you have a dark hair, some skin colour, you need a different type of laser. And if your hair is a white, pale hair, it won't work. But for most others, it's quite effective. It doesn't permanently remove it, but it permanently reduces the hair, which can make quite a significant impact on quality of life. And combined with a pill, it can be super effective. Why laser therapy for women with a medical condition that affects mood and quality of life is not covered as a medical treatment, we are really disappointed about. For example, many, and I'm not arguing that this is not valid, but many people who transition in genders can actually get access to hair therapy, to hair reduction therapy. But if you have PCOS as a woman, or as whatever gender you identify as, you can't get access to medically remunerated laser therapy. And that is that's a problem that needs to be fixed. So laser, the pill, metformin, after lifestyle. For some women, if they are at a very unhealthy weight already and it's impacting on their health, some of the medical therapies for excess weight can be effective, and there's some studies that are just about to be released showing the benefit. That's a risk and side effect equation. Like anybody who runs at a higher weight, that needs to be discussed with a health professional. Likewise, what we call bariatric or metabolic surgery may seem extreme, but it will significantly reduce the impact of the condition. And there's a study recently out of the UK on bariatric surgery in those who have PCOS and a high weight, and many of the features became far milder. So when you asked before, can you cure PCOS? You can't cure it from a genetic predisposition, but much like type 2 diabetes, if it is the higher weight, that is one of the main drivers for the severity of the symptoms in a particular individual case. And not all women with PCOS have a higher weight. About 25% don't, and in some countries it's higher than that. But the higher your weight, the more likely you are to manifest and the more likely you are to get symptoms. So things like that bariatric surgery, which again is very hard to access in places like the US and the UK and Australia. But if you do get access to the treatment, the weight loss is quite significant and many of the features and the severity can dramatically improve. Whether or not it's cured, hard to say, but it is fair to say that many of the features fall. Just like diabetes, it's a sort of, where is my blood sugar? Okay, I have bariatric surgery, my blood sugar will fall. Does it fall just below the level where you got diabetes or sit just above? Who knows? And over time, it does come back over time. So it's fair to say it doesn't quite cure it, but it may completely ameliorate the major symptoms only in those who are carrying quite a high body weight. And we do know from very recent research, that's not even published yet, Joyce, that specifically in women with PCOS, that a reduction in weight from those sorts of mechanisms can actually improve fertility and will improve pregnancy outcomes. So we know there are some that may need that. Hopefully we can help them to not get there. But if that happens, then those types of treatments are not a failure. They're not a cop-out. They're actually, it's a medical condition that needs treatment. And then the other issue is if you have infertility, what treatments can work. Really important message. A diagnosis of PCOS is not a diagnosis of childlessness if you want a child. The majority of women with this condition will have a family. If they have an adolescent diagnosis, they will usually have the family size they want, and they will not have any difference in being childless to any other woman who doesn't have the condition or any other person who doesn't have the condition. But most of them need help. And the important thing to know there, which actually is quite good in the UK in terms of treatment, is that the good news for most of them is that very few of them need IVF. Because the problem is those chemical hormones, and the eggs are okay, they just don't like where they're floating around. If we can use tablet therapy, usually for most of those women, which is low cost and not particularly invasive, we can click those hormones back on again and let women do their thing. And usually they don't need to have eggs removed and injections and sperm removed and, what we call in vitro or in a glass petri dish fertilization at high cost. So for many women with PCOS, they don't need that. And that's important for them to understand, because we need to make sure they're getting the least invasive, the lowest cost, the most effective therapy for them, and only escalating to those complex therapies if they need them.
Wow, lots of options there for sure. I've left changing the name till the end because we mentioned this before we started recording, and I think everyone can see that it's PCOS is not the right description now that you've just discussed everything. Can you just, I know you're not going to tell us what you want the name changed to, but tell us what you're working on now to look at changing the name.
Yeah, so I think the most important part of this is the emphasis that the call for this came from those with a condition who are sick of being dismissed and being confused and not having enough funding in research and education and guidelines and what have you, and care, and being put in that little box of something wrong with their ovaries, so we don't talk about it, and all those other features are ignored. And in fact, the most strong advocacy came from the UK, from the Verity group, which do an amazing job. So anyone with this condition should be following them on social media. Really amazing women, very strong leaders, and very passionate about making sure people are aware of the condition. But what we've done with those groups and with other groups around the world is reach out to those with lived experience and to all of the different clinicians and allied health and others who look after them and care for them with this condition, and said, look, what do you think about the name? And so 80 to 90% of women and their health professionals agree the name is confusing, and they agree the name is misleading, and they agree the name needs to be changed. They also agree that if it's changed, there are more benefits than risks. And they agree that it will only be better for research, better for education, better for care, less stigma. So all of those impact assessment questions have been addressed. What remains controversial, Joyce, is, okay, if it's not polycystic ovary syndrome, what is it?
Yeah.
And this is where it gets quite challenging, because one of the difficulties in many initiatives to change a name is no one can agree. And so it just never changes. So in fact, what we've done, and this is about to come out fairly soon with all those results from those 8,000 women and health professionals around the world, is we've got people to agree to the point that we need to change the name. So
Good
there's been
start.
an agreement we're going to change it. Yep. There's been an agreement on a process for that change, which is a consensus process it's a bit like the James Lind Alliance actually in the UK. So the process involves giving everyone a say through large-scale surveys about what they do and don't want. For example, we know women don't want the word androgen, that male type hormone in the name. They don't want the word obesity because of the stigma that comes with it. They don't want the word infertility, even though many doctors thought that those sorts of things should be in there because they're accurate. The stigma that carries is clearly inappropriate. So what we know is that what they don't want, and we know some of the words they do want. For example, endocrine is or hormonal is very, not the word hormone, but the word endocrine is something that most people with this condition relate to because it's an accurate description. So we know some of that, but the next process is going to be all the societies around the world coming on board, including the consumer groups, getting a really widespread survey out so we get everybody's voices, and then having a whole process of representatives come together to actually go through considering all the aspects of the change and coming up with a consensus, which doesn't mean everyone agrees, but a consensus new name. And then we go through the process to change that with the International Classification of Disease, or ICD, and with the electronic medical record systems, for example, so that people then recognise it. We have a transition period over a couple of years, and then we have a very large implementation program to make sure people are aware that the name has changed. And we've seen that with recent non-alcoholic liver disease. Fatty liver disease has been changed to metabolic liver disease. We've seen things like diabetes insipidus, which has nothing to do with blood sugar, has been changed to vasopressin deficiency. So we've seen conditions change because the name was causing adverse effects, and the change in the name improves outcomes. And that's really the story here. So after 8 years, and involving 8,000 people, when we've now got a mandate to change the name. But what I think the name should be is not relevant. It's the process we're going to take people on so we can get a consensus for the best name that will lead to the best understanding, the reduced stigma, the best education, more research, and improved healthcare and outcomes.
Fantastic work, Helena. Honestly, really, it's not an easy thing. And as I always say, we could all sit in our offices and we can design things and we can change names, but you are doing it totally the right way. We have to engage the people that this affects. I mean, absolutely, for sure. So I've called this podcast, Why Didn't Anyone Tell Me This? Now, Helena, in your career, I'm sure there's many topics that people have said to you. What's the most common thing you hear people say?
Are you talking about PCOS, Joyce?
Or anything, but can be PCOS.
Yeah. So why didn't they tell me about that? I think working in women's health, I think what I'm still struck by is the sort of almost, and societal, it's not just healthcare professionals, the almost paternalistic idea that we just don't need to do this as a mutually understandable shared decision making in context. The fact that women aren't really given appropriate information about healthy pregnancy and healthy birth, and they just go on a conveyor belt and pretty much do what they're told. The fact that we don't have really good data systems and information systems for those sorts of things in pregnancy. The fact that we still don't have good systems for detection of endometriosis and PCOS. The fact that we don't recognise that the debilitating pain that can occur with endometriosis and the devastating impacts of PCOS, we don't do it well. And there's a recent Cochrane review, Joyce, on shared decision aids. Do you know there is one in women's health, because apparently we don't need to be involved in shared decisions. So I suppose my emphasis here is that we need to not leave women vulnerable and reaching out to influencers and social media and misinformation by actually being respectful in the way we take people on their journey. When something's wrong, what is it? How do you find out an answer? How do you go on that journey with your health professional? How do you get informed and empowered accurately? How can you get the right tests? How can you know what the right treatment is for you? How can we respectfully partner with women in their care so that they don't need to go to misinformation and they are not vulnerable to the influences of commercial, motivated groups? And I think, to me, why didn't people tell me about that? I think we have done poorly in that area in the past. And I would love to think that over the next 5 to 10 years, and I must say again, the UK is doing very well with their patient and public involvement. It's not perfect, but it's a lot better than many other countries, and doing really well with the NIHR funding that you have on lived experience and on improving patient outcomes and on patient prioritised research through the James Lind Alliance. Travel the world around this sort of thing, and I know that the NHS is not perfect, but there are lots of things about the UK research system and the NHS that were amazing. And I know there's a bit of work to do now, but I do think there are many things you get right. So, long answer, but to me, the answer is moving to a respectful, informed partnership where information is accessible and where we have taxpayers' dollars going to a government that understands they have to protect us by having a healthy environment and making us as healthy as we can be, and they have to educate us so that we can do the best job of looking after ourselves, and we have to do it mutually respectfully and in an evidence-based collaborative way.
Here from me. Evidence-based is the phrase I say more than any other, I think. Now, Helena, I finished my podcast. I'm a little bit obsessed with health and happiness. And so I ask all my guests, what makes you happy and where is your happy place, Helena?
So what makes me happy, I have an amazing personal trainer who's lots of fun. So I do actually really enjoy my exercise because I find if I have to do it myself, I find it a bit hard, but I do really enjoy being fit. I am happiest when I'm with my family. I have two absolutely gorgeous daughters and a husband, and we're a very tight unit. So I really do enjoy my family. But my happy place, Australia's very, very hot in January, like 40, 45 degrees, and I don't like heat, Joyce. So every year, in January, we escape to a little country town in Canada and we ski over there quietly, little town, not exclusive at all, and it is stunningly beautiful very cold and just beautifully remote. So that is my happy place each year, and it allows me to recharge my batteries and start all anew.
Wow. Wow. I love that. I don't like the heat either. So, yeah, good move in January to go to Canada. I love that. And the very final question, which is always a bit tricky for some people. Helena, what advice would you give your younger self?
Interesting. Don't doubt yourself. As you said in the introduction, Joyce, I spent a lot of time doing leadership development for women in healthcare. It's a feminised industry, but it turns out that it is one of the most inequitable from a gender perspective. So the World Health Organization report, led by healthcare is led by men and delivered by women, is still very, very true. So one of the things I would have told my younger self is, don't doubt yourself. Get over your imposter syndrome where you think you can't do it and you shouldn't do it, and just go and be brave and do it. And I was really lucky early in my career. I was tapped on the shoulder to do an executive MBA. Would never have put my hand up to do it, but it was a leadership development program. Changed my life, changed my career, made me really courageous, and made me actually brave enough to fail. And I think the problem for so many women, both in their own care, in their family environment, in their workplace, in their career, have sort of fallen for the gender adage that we are submissive, feminine, quiet, don't make mistakes, don't put our head up, don't drive things, don't lead. I was lucky and I got that advice, and it's why I've run a leadership program and women in leadership for a very long time in healthcare, and love it. That's a happy place I have too. But I suppose I would have told my younger self, be courageous, you've got this. And I would have got my mentors a bit earlier and done it. But I think I still have achieved what I needed to achieve in terms of making an impact for women's health.
You certainly have. You're so inspirational, Helena. It's been an absolute pleasure, and you've answered all those questions about PCOS and much more. And given women, we've got to stand up for everything. So it's been an absolute pleasure, Helena. Thank you so much for spending the time talking about PCOS and more.
Thanks so much, Joyce.